About my presentation. So, vascular involvement, the CT is becoming much better. Okay, CAT scan, and where we still do a pretty good. Hold on. Let me pull up a slide. I think I do have that slide. Okay, so there are some vessels, especially in that when we take a look from the duodenal bulb, we can take a really good look at the portal vein. Okay, and if it's in the head of the pancreas, we can really see a nice plane in between if it is there, and we can provide the relationship of the mass to the portal vein and superior mesenteric vein. Okay, so if you look here. Look at this. This is a mass right here, and this is a mass right here. This one, what you are looking for is a plane. This white line, the wall of the portal vein right here. You see that? It's intact. So even though it's touching, but it's not breaking it. So this is separable from the vein. Okay, surgeons can separate that. This one is like really adherent, and it's like then they look for how much length of the vessel is involved. Based on that, if it's less than 15 millimeter, more than 15 millimeter, that also helps them decide can they take it to surgery or not. So with regard to portal vein and SMV, superior mesenteric vein, who still do pretty good with the EUS, but with other vasculature, especially arteries, if it's a clear-cut invasion, we can see that. But CT and EUS, they're kind of complementary to each other. So you have to take a look at both of those, okay? That's one point. Second part of the question was if it's a portal vein involvement, that does not necessarily exclude surgery, okay? They can go straight for surgery with what we call a portal vein reconstruction, okay? However, if it's a SMV involvement, then they need a neoadjuvant therapy. They still might become a surgical candidate, okay? When there is a SMA arterial involvement or celiac, they usually end up not becoming a surgical candidate. They are usually unresectable even after chemo or radiation. So that is called a locally advanced disease, and in those cases, they usually don't become a surgical candidate. Okay. That answered the question? Okay. Surgeons can correct me if I'm wrong.
No, I think we also have the same policy here, but we usually stop if there is invasion of the portal vein. But yes, our vascular friends can help us with the graft, or probably a pachymedullary unit who specializes in this, then we usually refer those patients to those departments.
Yeah. Well, bottom line is that is doable, but it might involve two specialty of surgeon. That's what we're trying to say. And so the other ones is usually you need a neoadjuvant therapy. Okay. Arterial celiac SMA involvement likely never going to become a surgical candidate. Okay. What am I doing now?
Last-minute questions about EUS. Anything else you want to ask? I was just going to tell you that you have to be careful because unlike some of the good centers, हमारे पास जो है scopes are limited, as I said. So be very careful. Don't try to be over enthusiastic, especially when you've got difficult FNA to do or something. Be very careful with the needle. You puncture the scope, you damage the scope, you've gone for 3 months, it's going to cost you at least $10,000 to $15,000. And so we're in trouble. So start simple, keep simple. Don't, I personally even now, I think that there is a risk and I don't want to do it. Somebody else can take that risk. I can't risk the scope, but I only have one scope in this room. So I think that's something that you need to be careful about. You need to make sure your technicians know how to clean it. It's very similar to the duodenoscope, but they need to be more careful with it because you've got a tip with the ultrasound probe there. You have valve channels that are different. So cleaning the scope should be good. You're going into areas, you're doing FNAs. You will be having patients infection transmission, etc. So you need to be careful with that. Therapeutic procedures, I don't think the fact that you can see a cyst, you should start draining it. I don't think that's my opinion. I think you should have stable hands. You should have done enough FNA, FNBs, whatever you have. Then you know when you were sticking a needle that goes where you want it to go, and you understand. You have all the tools that you need to do that, and you also have the tools to, in case you have any issues. So those are the tips. Be good to your techs and make sure they know what they're doing.
I think that's it, right?
Yeah.
Okay.